I'm Rebecca Goldberg. I work at the New York State Department of Health. We have offices mostly in Albany, but I work at the one in New York City. And I'm in the AIDS Institute in the Office of Drug User Health. And I have no conflicts of interest. So this is the work that we do in the Office of Drug User Health. The foundation of our work is about promoting harm reduction and addressing stigma. Show of hands, who feels pretty comfortable understanding and using harm reduction in their work? Who thinks it's a little crazy? That's good, thanks. I think when we start talking about harm reduction in substance use, it can be sort of an intimidating space because people who are harm reductionists, it's sort of like there's one way to think about the world, but I think that we don't really get more people to be thinking the way that we think without developing safer spaces to talk about the problems that it brings up and how to address having our own feelings when we're doing this work. So the core of our work is about addressing stigma. When people ask me what my job is, I say I try to tell people to be nicer to people who use drugs. That's it. I mean, I have a lot of things listed in my job description, but it's mostly about getting people to be nice. Some of our initiatives are these lollipop things I made. So we do buprenorphine access. So we have a team that does buprenorphine education to medical prescribers. We offer waiver trainings to increase the level of medical prescribers who are prescribing in communities like yours. And we do naloxone distribution. We mobilize local health departments, of which Nancy's team is one, and of which this symposium is a part of that initiative. We do syringe services. So in Nassau and Suffolk counties, Community Action for Social Justice, CASJ. Many of you may know Tina Wolf, who's the executive director and founder. So that's our one syringe exchange program in Long Island, and she covers both counties. It's strictly peer operated, so people meet up with individuals in homes and wherever is convenient for them. She's always looking for partners to help connect her clients to if they would like other services. And the thing about syringe exchange is that it's never really been just about syringes in and syringes out. There's always counseling provided. There's always risk reduction education provided. We send about, on average, 77 people a month into OASIS treatment facilities throughout the state just from our harm reduction program. So a lot of people think it's a place where you go if you don't want to make change, but in fact, lots of change is happening in harm reduction. Drug user health hubs. So Tina's program and 11 others syringe exchange programs around the state have become designated as drug user health hubs. And it's really a way to acknowledge the robust services that harm reduction programs have been offering. And they were also given extra resources to start providing low-threshold medical care with an emphasis on low-barrier buprenorphine, hepatitis C treatment. We've been curing several of our patients around the state, and also building collaborations with non-traditional partners. So building collaborations with local law enforcement, more and more with emergency departments. Someone comes in for an overdose, gets stabilized on buprenorphine, and then gets referred to one of our programs. And other interagency collaborations. So we work very closely with OASIS, the Office of Mental Health, with the City Department of Health and Mental Hygiene. I'm going to be talking about stigma. So I think the earlier presentations laid a nice foundation for us. I like to think about stigma as, when we talk about people who use drugs and stigma against them, it's sort of like it's the sexism or the racism of people who use drugs. So it's this implicit thinking that is even hard to understand. I was at a conference until yesterday in Atlanta, and people are talking about stigma, but in the way they talk about it, they're perpetuating stigma. I don't even know, I'm trying to think of a metaphor, but it happens all the time. So if you think about it like that, it can be really hard to start picking it up, but once you start to have a lens of, I see the world as a woman, I see the world as a small woman, you start to notice that the ways that you get treated differently based on a feature of who you are, how you present. So stigma and substance use. research has shown that stigma contributes to a lot of adverse health outcomes. People don't access the care that they need because they haven't had great experiences. So in New York City, we're having some trouble where people are overdosing, 911 is called, and people don't want to go to the emergency room afterwards. Should people go to the emergency room? Yeah, probably. That would be in their best interest. But they don't want to go because they've been treated poorly in emergency departments. So if you start to treat people better in emergency departments, people will want to get that care. It's not that they don't want to get the care, it's that they don't want to get treated poorly while trying to get the care. Stigma also perpetuates an inability to complete treatment or to feel like the success or the marker of achievement is just way too high and not achievable. And it increases risky behavior. So if you think that people are judging you about something that you do, you're going to do it in the shadows, you're going to not tell someone, you're going to close the door, and you're going to put yourself at a greater risk of disease transmission and also of overdose. Okay, so this is a little complicated slide. On the left-hand side, on the top, you have stereotypes and prejudice. So in the middle, public. So this is like just when you talk to anybody about people who use drugs, and specifically around opioids, there are thoughts that they're dangerous, that they're immoral, and that they're to blame for their disorders. And so then the action or the discrimination that leads to is that people won't hire them, so they can't get employed, landlords won't rent to them, primary care providers and others may offer a different kind of care. And so all of the ways that the action and the discrimination plays out is that it actually further disconnects people who are actively using. And so if you're trying to bring someone back into a community, reintegrate them, help them see the opportunities to connect with others, disconnecting them from stable housing and from employment is not going to do that. So stigma gets internalized. When you are perceived as being a certain way, you start to believe that maybe you are that certain way too. And it plays out by looking like, because I use opioids, I am dangerous, I am immoral, I'm a risk. Lower self-esteem, lower self-efficacy. You start to think, I'm not employable, I don't have skills that could be used for a job. And so it means, why try? Because people have given up on me, why should I believe in myself? So it's hard to maintain that hope when you feel like you haven't gotten that from others. And so then you also want to avoid being labeled as someone with substance use disorder or someone who uses drugs because of all these negative things. So if you don't have those things, and if nobody knows, and if you're not accessing treatment, then you can't be judged in that way. So this was a study in 2012 in Australia. And they surveyed people who inject drugs, and over 80% of them had experienced some kind of discrimination in healthcare settings. And we can think about it as far as the kind of care that people get, like if a prescriber assumes that they're drug seeking, they may change the kind of medications that they're getting, but it could also just be the way that a receptionist treats them when they walk in, not letting them use the bathroom, things like this. We've talked a little bit about language, so this is a slide on the left-hand side, some stigmatizing language that we've made reference to. A drug addict, a drug abuser, being clean or dirty. So people can't be clean or dirty. Their urine could be positive or negative. We say a person who uses drugs or people who use drugs because it puts the person first. So if I smoke cigarettes, I'm not a smoker, I'm someone who smokes cigarettes. So the behavior doesn't have to define me. And that goes, it sounds like a small distinction, but it goes a long way as far as people thinking that they're still people, they're not just their drug use. So I covered this. Poor appointment adherence, or just sort of having an ambivalence about whether or not to get care. Also, people are not sure about how disclosing the truth about their behavior is going to inform how you're going to treat them, and so I may not disclose everything. I mean, probably, show of hands, who has lied to a doctor before? Yeah. So, I don't get a report card when I walk in of like, I'm really judgmental or not, but I just assume like I don't know. You know, they ask you about some really personal things and you've just met them. Yeah. Or like you may have been honest with one doctor and then, you know, they kind of like were like, ooh, you know, to one of your answers, and then why would I ever give that answer again? But does it inform the kind of care that I'm going to get? For sure. So I may not get what I need because I don't want to disclose it, even if I do go in. This was a study that I wanted to point out. So at a mental health provider conference, they gave out little vignettes about a sample patient. And in one vignette, the patient had a substance use disorder, and in the other vignette, he was a substance abuser, and everything else was the same. And then they asked people questions about the kind of care that he should get and what would you do with this kind of patient. And what they found was that for people who had the vignette about a substance abuser, they saw more personal culpability for their problems. So they were more to blame, and that there should be some level of punitive action, as opposed to thinking about it as a chronic illness where like we don't blame patients with cancer for getting cancer again. And yeah, that people who had been reading it as a substance use disorder, they did not see any kind of, like they associated the person with being a victim of the condition and not, they didn't think there should be disciplinary measures taken. Person-centered language. It can improve quality of life, self-worth. It helps reconnect people back into their community and their relationships. Reduces the isolation that they may have felt from providers and increases access to care. So some ideas for integrating this. Pay attention to how your patients want to talk about their substance use. So you can use terms that they use as opposed to making it very clinical, but also consider like if they identify in a way that may have meant that they internalize the stigma, you know, be considerate about not just using the words just to use their language, but to think about, okay, if I'm saying it, what does it mean for me to be using that as a provider? And also when in doubt, ask. I think, you know, if someone says, oh, I'm an addict, or, you know, if they identify as some term that you may not use clinically, you could ask them about it. You know, why do you identify like that? What does that identity mean to you? Do you want me to call you that? Do you like it when others call you that? And see, like, where is that coming from? You could also integrate it into your office culture, into your intake forms. You could look at some of the characteristics of people who have not returned for care and start to see what were the similarities that they had. Oh, all of these people answered yes, that they're actively using at intake, and they didn't come back 30 days later. And as I'm sure you know, you guys have probably like focus groups or consumer advisory groups, ways for people to provide feedback about their experience of the services. And I think like training all staff and being culturally competent. So like maintenance staff should also know that when they encounter someone in a bathroom, what to do. It's not just the providers that inform someone's experience. Okay. Tell me about what harm reduction is to you. You can just raise your hand, shout it out.
Use less.
Using less. Uh-huh.
Meeting the person where they're at in regards to their use.
Meeting the person where they're at in regards to their use. Preventing death and disease.
Listening and empathizing.
Listening and empathizing. No value. Or valuing judgments.
Using safely.
Using safely. Can harm reduction be relevant for someone who's not using? Yeah.
I think so for everybody.
Yeah. Do harm reduction programs serve people who are not using? Yeah. So I was thinking about harm reduction. We talked about like what do you do when you know there are family members who have recognized a problem that someone has and they want that family member to get help. Harm reduction can be an entry into making change, but what's also great about it is that the person doesn't have to commit to making change in that moment. I think that part of why it's really difficult for people to say like, okay, let's go start treatment, like take me to the detox facility, is because that's a huge change. And if any of us have tried to make behavior changes with diet and exercise, with nail biting, with like any behavior that we've been doing for a long time, it can take a really long time. Like I think of it as like if someone told me to go get a PhD in 6 months, that feels like impossible because it is. But I think that kind of impossibility is what it feels like if someone is telling you need to change your entire life around. Part of what's helpful about having access to low threshold buprenorphine is that someone can like dip their toe in water and see like, maybe I could try making change. Let me see what this medication is like. Because if it's an all or nothing thing, we lose a lot of people who are like, no, that looks really terrifying. But what if I just go and like someone treats me nicely in this office? So harm reduction is a lot about building rapport with people so that they come back. So there's a lot of trust in the relationship with the provider. What else? Yeah?
So what are things that have a negative harm reduction principles rather than something positive? It bothers me.
Like what?
I don't know, like building bridges, respect, I don't know. I think
Yeah.
what you're saying, but it's the title is harm reduction.
Yeah.
And it's sort of, I'm a positive person, and I feel that people go on towards more positive concepts,
Yeah.
things like that.
Yeah. Yeah, we could probably use for some rebranding, I think. Yeah.
I've never heard of it before, but.
Yeah.
Wouldn't you be taking,
Rebecca, do you mind just sharing?
Oh,
the mic?
sure,
'Cause I
yeah.
don't think anyone else could hear back there.
oh, God. I think it's important not to neutralize the idea that this is something that's harmful. So, I mean, it is a crisis, and let's do it together. Let me help you with this. I understand what you're saying, be positive, and you can say, I can help you with this. We will get help for this. It is a crisis. To not minimize the importance of what we're dealing with.
Yeah.
Along the lines of what you're talking about, when I came into the field was a little different. And to a certain extent, there's still some of that here today. This is the way you do it, and I remember at that point, you would sit down and you would do an evaluation on somebody, you would come up with a treatment recommendation, and there really wasn't negotiating, right? Because we are the treatment professionals and we know what you need. And as time has gone on and you go through life experiences and you mature in your field, I found myself getting into interventions at one point, and I found that a more productive format, because the family's always, and I think Sandy had spoke to this, it's always about detox and rehab. And I said, we're not going to talk about rehab. What we're going to talk about is we're concerned. Here's why we're concerned. Here's what our thoughts on what we'd like to see. And what that usually led to is the ask was to see a professional, to be evaluated. Right? And the professionals a lot of time, if they have motivational interviewing skills, have the ability to establish a therapeutic rapport, to your point before, that's a lot less threatening to think of, you want me to give up something that I've been doing for 15 years, go to a place where I don't know anybody, leave the world as I know it. I mean, that's a huge lift. But getting them to be willing to see somebody individually, that is a little more doable, and then hopefully the skill of that person. And not everybody needs to go there. So maybe you start there. Maybe you start with an individual therapist who then says, you know what, I think it's great you come here, but I don't think I can meet all your needs. Would you be open to something along those lines?
Thanks. Any other comments? Harm reduction? Yeah.
Thank you. Just very briefly, piggybacking off what Anthony was saying, I think the important thing to also kind of understand is, this is a behavior that's been happening for a very long time, so it's almost become a coping skill in a sense. So I would imagine it has to be really scary to kind of hear, okay, this is something you're no longer allowed to do. So I think the harm reduction model really kind of gradually, opens up different doors that maybe doing it overnight would be really scary.
Mm-hmm. Yeah. One of the things I've noticed, so I used to run a harm reduction program, and now I'm on the public health side of things, and there's a lot of public health interventions where, we think that something tragic happening to someone is going to be this wake-up call of oh, let me change my life in an hour. an overdose, a friend's overdose, an arrest. And so there's all these programs that are geared towards like, well, great, as soon as they're arrested, instead of arresting them, we'll divert them into treatment. But who's to say that an arrest is going to motivate someone to get treatment? If something, like if I went through some crisis and the coping skill that I have had for so long is to use, I'm going to do the thing that I know how to do. It may not be that wake-up call. So I think it's good to have, you know, the reason these programs exist is because you want to have an easy touch point if someone is motivated there, because there may be some motivation. But for many people, that may not be the moment that they want to make change. And so that should also be okay. The other thing about harm reduction, and that I think gets lost when we talk about substance use disorders, is that you know, the underlying systems that have failed many people and that often lead to substance use, if you don't have great education, if you haven't had great employment, if you have had a traumatic childhood, if you didn't develop healthy coping skills when you were young, if you didn't have good role models, all of these markers as you mature, those are things that will facilitate using. And so if we're not addressing those, if we're not addressing someone's really crappy housing situation, we're going to ask them to change something else that's actually helping them get through being homeless. That's going to be tricky. So often in harm reduction, we ask people, what do you want to work on? And they may say like, well, my daughter's really pissing me off these days. I'm like, okay, let's talk about your daughter. It might be months until they talk about their substance use with us. But the point is that like we're invested in the thing that they need to stabilize so that they can make other changes if they want, when they want. Okay, people who use drugs are more than their drug use. This is a fun slide I took from one of my coworkers. So Dr. William Halstead is one of the founding fathers of American surgery, and he used to experiment with numbing medications on himself. And so he had an addiction to cocaine and morphine, and he practiced medicine for many years while using. You know, and he was productive for a good point of that. And it's important to remember people who use drugs are the ones who have organized and created syringe exchange in the first place, naloxone distribution, methadone programs in jail. So, you know, we like, you know, New York State Department of Health can be like, oh, we're so great, we have syringe exchange, and, you know, we've reduced HIV infections by a bajillion percent. But really, like, having the supplies is not the intervention. It's the fact that if people are given access to an option that's going to protect themselves, they're going to use it. They just need to have access to it. So if we make things accessible, they'll use it. I'm not forcing anybody to do a syringe exchange, but they show up because there's something of value that they get every single time. Thank you.